Hi, I'm Michael Mickey, and this is my house project, and I'll ask you a few questions.
Okay. Good to meet you. Thank you for having me.
First question,
Sure.
did you ever think you would save lives someday?
You know, I always prayed I would. When I was little, I was kind of like you, very curious about things and wanted to see how things worked, and you always want to help people. So when I was in high school, not nearly as young as you though, I spent some time doing research in the hospital in a place called NIH. And when you spend time there, you see how important it is to help people.
Yeah.
I wanted to. That's exactly right.
All right, how long does a surgery take?
Well, it depends what sort of surgery we do. Dr. Jimenez, who's my partner, and myself, we work on the brain and the spine. So a surgery, depending on, and we also work on nerves. A nerve surgery could take less than an hour.
Yep.
A brain surgery can take anywhere from a few hours to about 6 to 8 hours. And a spine surgery could be a small surgery that we can finish in 2 hours, or it could last anywhere from 8 to 12 hours. So it differs, and we try to mix it up so we have enough energy.
Okay. What is the youngest patient you've dealt with?
Oh, when I was in residency, I dealt with little kiddos too. Here we do primarily adults, but we'll take care of sick kids. But I've dealt with kiddos as old as 1 or 2 days old. Sometimes actually a few hours old, because some kiddos can have congenital defects
Yeah.
in spinal surgery that you can have something called a Chiari malformation or something like that. If they happen right when they're born, or a myelomeningocele, you usually have to operate as soon as they're born. So maybe a couple minutes old.
All right. Can you tell me the story of your scariest procedure?
I sure can. It's one of the first times I was in the operating room when I was a medical student. And I was working with one of the residents there. So the way it works, you go through to college, you go into medical school, and you go into residency. So when you're a medical student, you follow the resident. And I remember I went to medical school at Johns Hopkins. And that's a pretty rough neighborhood.
Yeah.
And one of the kiddos, unfortunately, it was actually a 9-year-old child, if I remember correctly, had a brain bleed because she had sickle cell anemia. And we had to go into the operating room and work with her quickly. But it was very scary. For the first time, he let me actually use the drill to open up the brain. Your first time ever doing it, oh man, it was very scary. But that's how you have to kind of learn how to do anything in life. You have to be able to control your fear, intrinsic anxiety, and be able to use all the knowledge you have to help somebody.
All right.
Yeah.
Do you what was the grossest thing you've
Gross.
ever seen?
Oh, that's all. It all's kind of gross, whenever.
Yeah.
The anatomy is very beautiful. The anatomy of the brain and spine is probably the most beautiful anatomy you'll see. But when things can get bloody, it can get a little messy. That's our goal. Our goal is to kind of be as safe as possible in that kind of bloody mess and make things work.
All right. What is it like being a neurosurgeon in a small community without
Yeah.
in a big community?
It's fantastic. So I've worked in both places. I've worked in big cities, and I worked this is my first time in a smaller city, but I love it. It's just like anything else. If you have some people that you enjoy working with, whether it's like Mary, who you met, or Dr. Jimenez, or whoever your team is, if you have a good team to work with, you can help pretty much anyone and everybody. And the advantage of being a small community, you can help someone and you see them a few weeks or a few months later out in the shopping mall or the Walmart or whatever, and you're happy to see them do well.
All right. I'm actually familiar with the TBI. I had one when I was 6 years old.
Wow.
So I was in Reno, Nevada.
Yeah.
And I was at a Major League Baseball game, and a foul ball came right to my head,
Wow.
and so yeah.
Did you lose consciousness and all that sort of stuff? That's
No.
good. That's
Yeah.
good. That was scary. I'm glad you're doing well.
Yeah. Do you have a model of the skull?
Yeah.
And-
You want me to bring it to you?
Sure.
Yeah. Okay.
All right.
I'll bring it right to you.
Okay. All right.
All right. Give me one 1 second. To a person. Okay? This is what we look like. Okay? It's actually more like this. Where you have your skull, you have your spine, it goes into your pelvis. Okay? Now we start off with the skull, and the skull has different bones. There's a front part, there's a back part, there's a side part. And if you open it up, you will see, there should be at least, the brain. Okay? So what we do as neurosurgeons, whenever we have to access the brain, we make a small hole here, spine. So, you know, if you feel your head, you feel your noggin, feel that hard bone?
Yeah.
That's what this is. And that's called the calvarium, okay? So whenever you want to have access to the brain, you have to make a hole in the bone, depending if we're going to go for a tumor, if we're going to go for a bleed, and you try to access that area. When you open that, you're functionally going to see this, okay? And this is your brain. Your brain is made up into little parts. It's made up into the frontal lobe, the parietal lobe, the occipital lobe, back here. This is the bottom part, and this is where your cerebellum is, and this is where your brainstem lies. So the brain is very intricate, how everything connects from here to this area called the brainstem, into your spinal cords, into your nerve roots, and then into your nerves. So we get involved if anything at any of those levels get blocked or hurt. Okay. So that's the skull, that's the brain, this is the spine. And your spine is divided up into the cervical spine. There's 7 segments. The thoracic spine, there's 12 segments. And the lumbar spine, which there's 5 segments. And let's turn this over. When you open all this up, you can look in, you'll see the spine. Okay, so see these things right here, these little ridges? That's what you feel in your back when you start feeling those little points in the back. And the same sort of thing, when we have to access the spinal cord, we make little holes in the bone, so you can actually see the nerves a little bit better. But we're pretty much no different than this model.
Yeah.
Yep. Okay, what else can I answer for you?
Can I take some pictures of like some of your tools? And
We don't have any. Let me
Okay.
look into
All
that.
right.
Let me give me 2 seconds. I'll see what we have. Most of our tools are in the operating room.
Okay.
And those are usually kept sterile. I'm
Okay.
pretty sure we can have some tricks up our sleeves and find
Okay.
them. Okay. Take a look at this. I'll be right back.
Alright.
What's great about neurosurgery is you get to not only diagnose a problem, but if you can figure out what's wrong, then you can potentially fix it. So let's actually do everything in order. Come in with this, you do the surgery with this, and you send someone home with this. Okay, what does that mean? So let's say our friend comes in here and he's having some headaches or some back pain or something. We have to make that diagnosis. So in order for you to be a good surgeon, you actually have to be a good diagnostician, which means you have to be able to use hints and clues to figure out what's going on, even before you can get to the fun stuff of cutting. So if someone comes in, let's say, with some sort of abnormality, weakness in his hands, or a kid having trouble with vision, what we do is we do a full exam. We look at you from head to toes. We look at you how your eyes work, how your mouth works, how your hands work. So we have to make a diagnosis based upon the physical exam. This is a reflex hammer. So why don't you come over here? You put your arm out. So
Okay.
take a picture of this, okay? Just relax your arm. And what we can do is when we can check your reflex, right? So if you'll see like that, you'll see your hands, so you can relax. You get little reflexes. You can't see it very well because your hands are on there. Basically, we can check your reflexes with a reflex hammer. We can check your sensation with this. You want to feel this? It doesn't hurt. It looks scarier than it is. Put your hands around. But basically, what we can do is we can say, hey, can you feel that? So some people who have some problems might be able to feel it in one hand, but not the other. And that tells us where the problem might be. So the first step of any neurosurgeon that they have to become, the reason you go to school for 18 years, is you have to be able to make the diagnosis. And you make the diagnosis with, you're kind of like a detective. With all the information that you have, you look at the MRIs and CTs, you do a physical exam, and then you try to guess where the problem is. Now, if you know where the problem is, then this should be enough to fix it. This is a scalpel blade, we won't open it. We can open it actually, but I won't let you touch it because these can be very sharp.
Okay.
But this is our number one tool. Okay, and this is what they call a 15 blade scalpel. We make our incisions. This is the cutting part. This is the flat part. And if we have to get into this part of the brain, we make a cut, open things up, and then we have to drill into the bone. So this is really one of the most important tools because we have the surgeon's simple knife.
Yeah.
Then you have other little tools you can have. This is called a hemostat. This is called a micro scissor, and you can use this to help you take out whatever's causing the problem. And then this is just a simple, if everything goes well and we see you back in the office in 2 weeks, you know those staples and those head wraps you see people on television?
Yeah.
Well, then we can take those staples out and then they can go home and be on their merry way if everything goes well. Okay?
Yep.
So
Let's
you're,
move around here for a minute.
yeah.
What?
We had an injury at a baseball park,
Yeah.
and so
What did it end up doing?
Yeah. so he's
So
got
he did have a
couple of plate you can feel in there.
Yeah,
So
that's right. So did he have a baby girl?
He had the dura was it just you could have set the baseball like right in the head there. Just it was a shot down the left field line at a semi-pro game, and so he didn't ever lose consciousness till he was just headed into the surgery room, and then when we saw him, of course, they had it sewed up like a baseball from there all the way back up to here.
It's actually called one of our famous kind of horseshoe incisions.
Okay.
Basically, so if you're comfortable, I can show you. Basically, you probably had a fracture or a depression of your skull right here.
Mm-hmm.
And in order for us to get there, we had made like about right. So then what we did is they made a fracture. But anyhow, so that's amazing. You healed very well. That's awesome. I'm glad you're here to do this interview with me. Okay, what else can I answer for you?
I think.
Have a seat. We can
All
answer
right.
questions. There's no rush. Don't feel rushed.
He's inquired of us as to whether those plates can come out.
You know, there's no reason to take them out. Usually what happens is the bone kind of grows over that plate, and the risk of an infection going in there and taking out the plates are higher. Unless it's protruding or it's causing any uncomfortableness, then sometimes people go in and take that out. But if you don't have to, the risk of an infection of going back in is a little bit higher than the first time around. But unless, of course, he's feeling it bothers him, they could potentially do that.
If the screws bother him a little bit, do you ever just take the screws out?
Well, you could. The problem is, it depends. You probably have to get a CT scan to make sure the bone that has fused.
Okay.
But if he had like a compound fracture, I'd hold off. I really would, unless it's protruding or it kind of gets into the rows of the skin.
Do you use those same tools to go back in, to take those out?
If we had to surgery, yes, we'd use them. I'll tell you exactly what we do. You'd use the knife to follow that same incision, or you'd open up your scalp, find out where the screws are, and take it out.
Yeah.
But again, I wouldn't be any rush to do that because those might be things that are keeping that kind of fracture together.
Mm-hmm.
And even though it happened a while ago, you hope that bone fuses. You don't want to make sure it's not going to kind of fall apart again.
Yeah.
Okay, what else can I answer for you? You want to see what a brain tumor looks like on an MRI?
Sure.
Okay. Let me put them up because for patient confidentiality stuff, and then we can
All right.
show it to you in a second. Okay.
Okay.
And don't worry, you won't be sick. This is, you remember we were looking at the brain. So this is a picture of the brain, right? And you'll notice here that there's this big thing here that's white.
Mm-hmm.
That's a person who came into our office a few days ago who had some headaches and some issues with just overall not feeling very well and some weakness.
Mm-hmm.
You'll notice that he has a big tumor here.
Mm-hmm.
So big white thing's a tumor. So what we're going to try to safely do is remove that tumor, just like before. We're removing that skull. This tumor is right here in this area. And safely kind of dissecting that tumor away from the normal brain and take it out. So that's pretty much, we can do anything like that to fracture. We do with people who have spine fractures.
Mm-hmm.
So we get to kind of do a little bit of everything. Okay?
Yep.
Any questions?
Is that on? Am I looking right? Is that on the outside then, or is
No,
it kind
it's
of
in the MRI.
internal a little bit?
It's
there?
it's an MRI and inside of the brain. So this is the skin right here. This is the skull here.